Hello and welcome to a new episode of Home of Medicine podcast in our new home with the Royal College of Physicians, Edinburgh. My name is Ben Lovell. I am a consultant in acute and general medicine and I work in London, and I'm here with my co-host.
Hi, I'm Amie Burbridge. I'm a consultant in acute and general medicine working in the Midlands in the United Kingdom. Thank you, Ben.
So my records tell me that it is your turn to present a case today for me to try and work through. So whenever you're ready, I am all ears.
Absolutely, fab. So this is a case I saw very recently, Ben. This is a 62-year-old female who presented to the same day emergency care unit, and she was referred by her general practitioner. And the referral letter said, "I'm very worried that this lady has had a migraine or a transient ischemic attack. Please assess."
Oh, and there's you with your neurophobia.
Do you know, I met somebody a few weeks ago who said he would really like to cure me of my neurophobia by me going to headache clinics and doing lots of neurology. I was like,
That would
yeah,
work.
actually,
Yeah.
yeah, absolutely.
That's kind.
So, on further history taking, the patient was at work 5 days prior to coming into hospital and said that she had floaters in her left eye. And the first 3 digits of a phone number were missing. She felt pressure over the eye, the left eye, and that felt that she needed to really press on it because it was uncomfortable, not painful, but uncomfortable. She felt quite sensitive to light. It lasted 20 to 30 minutes, and she says that the floaters floated off.
Good.
Any thoughts?
Please.
Yeah. Any thoughts?
Okay, I'm writing this down. And it lasted 30 minutes. Well, do you know what? Fair play to the GP. Yeah, that could be it. Yeah, I could believe. So she's sitting at work. She's feeling well.
Well, yeah,
Until
absolutely.
the moment she cannot see 3 digits of a number in front of her
Mm.
because there is obscurations to her vision, which is blocking it. And that's associated with eye pain, right? And she feels like she wants to rub the eye a little bit.
Absolutely.
And it lasts 30 minutes and goes away. Is it a headache or is it an eyeball pain?
So I was trying to dig down a little bit deeper into the pain. There was no pain in the head at all. It was in the eye.
Yeah.
There was no headache at the time.
Yes.
And it was very much over the one eye. She was, and I was very, did you have any pain anywhere in your head? Any tenderness? No, it was in my eye. Okay. So the Thursday and the Friday of that week, this happened on the Wednesday, were fine. However, on Saturday, she was watching television and she developed floaters, and she describes a ghost in her left eye. And she had difficulty watching the television. She felt tired and went to bed at 6 o'clock. She woke up at 3 o'clock in the morning. Her left eye was painful again, but she was able to get back to sleep and she slept well. When she woke up on the Sunday, her vision wasn't right in that left eye and she couldn't see clearly, but she slept well, went out for lunch with her family, no problems, went back home, slept well on the Monday, went to work. She denies nausea, vomiting, any upper limb and lower limb weakness, any speech changes, any hearing changes. Any thoughts?
How many episodes did she have in total? 2?
She had one on the Wednesday,
Yeah.
she had one on the Saturday, woke up on the Sunday morning and she still felt unwell. So she still describes this ghost in her left eye. And I was like, what do you mean by a ghost? Did a curtain close over your eye and then the vision went? She went, no, it wasn't a curtain. It feels like there's a ghost. And she was still describing this ghost like I guess like one of those traditional ghosts where you like wear a, I don't know, a white
Like a
sheet
sheet over your head.
Yeah, absolutely.
So yeah, sorry, I'm just being super clear about the timeline. She has one episode Wednesday,
Yep.
which lasts 30 minutes.
Yes.
One episode Saturday,
Yep.
which lasts longer. And what day are you seeing her?
So I'm seeing her on the Monday.
Okay, where she's still having an ongoing issue with her vision.
Absolutely.
Okay, that's her second episode. And is she got a headache when you see her on the Monday, or
No.
the eye pain is gone? It's just vision.
So she'd been to see the GP that morning, and the GP thought, actually, could this be a migraine?
Yeah.
I wanted to know whether this was an aura. Did she have zigzags in her eye, these classical obscurations? But she said no, it's like a ghost. She'd had some metoclopramide and some sumatriptan, which hadn't helped at all. In fact, it made her feel a little bit nauseous, which sumatriptan can sometimes do that.
Yeah. Right. Okay. So I wrote 5 things down here. I've scribbled TIA, migraine, trigeminal autonomic cephalalgia, optic neuritis, ophthalmic. Okay. Ophthalmic is my everything related to the inner workings of the eye, which is a total mystery to me. So let me just work through it. TIA. TIA should not last more than 20 minutes. 30 minutes, I'd let her have that. But no, if she had the second episode on the Saturday and she still got symptoms today, that is not transient by definition. That's not a transient ischemic attack. Has she had a full-blown stroke? Well, in the sort of, it doesn't quite fit. She's got visual obscurations. She's got visual problems, and that doesn't strike me as a stroke. She might have a retinal artery occlusion, but I'm filing that under ophthalmic, so I'll come to that at the end. Second option, I wrote down migraine. Migraine is such a wide umbrella term for so many different presentations. I had myself something called an acophalgic migraine with aura, where basically I just have an aura but no headache at all. I just get twinkly lights for 20 minutes and then no headache, which is a great migraine to have if you're choosing which migraine you want. The one without the pain is fantastic. But you can get these visual obscurations. Eye pain, okay, yes. Migraine is usually a unilateral headache, a side-locked headache, we call it, because migraine means half your head, hemicrania. Although you can get holocranial migraines. Is she now in status migrainosus with a persistent aura? I think it's possibly, but I don't favor that as a diagnosis because, as I say, there's no pain. The pain when she did get it was around the eye. I'm assuming, although you haven't told me, she doesn't have a history of migraine.
There is no history of migraine at all.
Okay.
She is diabetic, type 2 diabetic.
Okay. She's 62, so a de novo presentation of a primary headache disorder is unusual in people over the age of 60. So I would be a little less keen about labeling this migraine. The next thing I wrote down was the TAC, trigeminal autonomic cephalalgia. These are the nasty headaches, like cluster headaches, which really focus around the eye. And I wrote that down because you said eye pain. And you get really bad eye pain. You get tearing and conjunctival fusion. You get ptosis of the eye. You get excruciating stabs of pain through the eyeball. It doesn't sound like that fits the bill. And the visual obscurations don't fit. Optic neuritis. So a demyelination disease, a first presentation of MS, but it is something with optic neuritis. Now, what goes for that? Eye pain, visual obscurations. Usually they get a scotoma, a central scotoma. So maybe when she was trying to focus on this phone number and she couldn't see 3 digits, that would fit. She's sensitive to the light. Actually, that would fit as well. So I'm going to keep that on. I'm going to draw a little circle on optic neuritis. And the last thing I wrote down was ophthalmic ? And I'm afraid this is terror incognita for me, with the emphasis on the word terror. A vitreal hemorrhage, a retinal detachment, a retinal artery occlusion, a retinal vein occlusion, which is causing pain and visual problems to the eye. I'm going to have to dust off the old ophthalmoscope, aren't I, and wave it around, pretend I know how to use it. But I might actually have to summon a very clever ophthalmologist to help me out with that diagnosis. Now, you asked me, what am I thinking? And that was what I was thinking. Those five things.
Brilliant. So, not too dissimilar to me, actually. We often do think along the same lines, so that's reassuring. So, further history, as I've said, she denied facial weakness, facial numbness, changes in speech, hearing. She had no pins and needles, and she was able to walk throughout. There was no confusion. She had no chest pain, no shortness of breath, no cough, no wheeze, no pyrexia, no bowel, no bladder problems. As I say, her past medical history, she was diabetic, she wears glasses, and she's been on HRT for quite a long time now. She's completely gone through the menopause, but she's still taking the spray of estrogen and progesterone tablets. And she's also on Mounjaro. And she's been taking Mounjaro for 3 to 4 months, and she's lost a significant amount of weight. She's pretty active. She takes a dog walk once or twice a day. Doesn't really get short of breath or, exhausted by that. She also has an underactive thyroid for which she takes thyroxine for just a small dose. She doesn't drink. She doesn't smoke. Never used any recreational drugs. No significant family history of note. So I was in clinic, so I thought, okay, I'm going to do an examination. So her blood pressure was a little bit on the higher side. It was 146/91. I did it on the right, that was on the left arm, I did it on the right arm, and it was 142/87. So there was no significant difference. And I didn't necessarily think there would be, but I just wanted to double check. So she was a little bit hypertensive. Looking at her eyes, her left eye was injected. So, and it's got like red and sore, but the right eye was fine. Her pupils, she was quite sensitive to light, but she could move her eyes. There was good range of movement. Cranial nerve number 7 was normal. She had normal sensation of face. Her tongue movement was normal. Now, I did attempt fundoscopy, and I think, like you, Ben, I do own an ophthalmoscope. It's even got my name on it. I have tried over the years to learn how to do fundoscopy well. I still don't feel confident at doing it. And I think that's part of my neuro-ophthalmophobia that I have.
Oh, it's getting worse.
It's getting worse. Yeah. But I did try. I couldn't see anything significant. So I can pick up on papilledema. I didn't see any papilledema.
Okay.
So nothing really on the examination apart from an injected left eye. Her peripheral range of vision was okay. It was very difficult to assess, but she said her visual acuity was grossly reduced. But to be honest, I didn't really feel that I could assess this properly in clinic. I didn't have the proper charts. However, I did get her to read something. Her vision was a little bit blurred, to be fair. She couldn't read properly in the left eye. This ghost was still there in the left eye.
And that's the injected eye, isn't it?
Yeah.
The one that looks a bit red.
Yeah.
So she can't see properly left eye.
No.
And it looks injected. Okay. So I've written a few things down. What was she taking for her diabetes? Are you on injectables or orals?
So she's on oral medication, as well as Mounjaro. The Mounjaro she was actually buying privately.
Yeah, most people do, don't they? Now you've said Mounjaro 3 times. I'm racking my brain, but I can't think of any sort of eye complications from Mounjaro that I know of. Although I know it's a relatively new drug. The HRT. Don't think so. And then the diabetes, eye complications, diabetes, we all know about diabetic retinopathy, but it doesn't present acutely like this with eye pain, does it? So I don't think that's got anything to do with it. And then she's a little bit photophobic and the eye looks injected. Oh, I just keep coming back to thinking this is an eye problem. And absolutely no shame to you or to me, but does someone need to do a proper eye examination? Looking for, if it was optic neuritis, for example, you can see papillitis, which looks like a hyperemic optic disc, but I can't swear that I can see that. And if it's retrobulbar neuritis, you don't see anything. But I think it'd be interesting to do with that. Glaucoma presents usually with severe eye pain, a red eye, a sort of a funny shaped pupil, but it doesn't come and go. It can give you visual obscurations, and the patient normally feels very unwell. They vomit because of the high intraocular pressures and feel pretty rotten with it. It doesn't sort of go and then for 30 minutes and go away again. And so it doesn't quite make sense for me. Did she have any interesting blood work that I should know about?
Do you know, I didn't do any blood tests.
That's okay.
I mean, I did a glucose, and her glucose, it was 6.7 in the clinic.
Mm.
What blood tests would you have done, or should I have done?
Oh, I don't think you should have done any blood tests particular. I just wondered if there was any there. For example, if her CRP was 400, I'd find that intriguing, and I might start considering doing some brain imaging to see, looking for things like abscesses or something like that. But no, there wasn't a particular test. I thought this will clinch the diagnosis. I mean, I think migraine's getting less and less likely because a migraine doesn't give you a red eye, does it? I mean, the photophobia does go with migraine, but the red eye absolutely doesn't at all. So I keep coming back to a primary ophthalmic problem here, but I'm struggling to put my finger on unless there's any more information which might help.
This is a situation I was in. So I was in clinic, and I had this patient in front of me, 62-year-old, diabetic, HRT, wears glasses, didn't have the typical migrainous symptoms with the obscurations. It was more like the ghost, and she describes it as a ghost, like this floating ghost in her left eye that, to be honest, since the Saturday, Sunday hadn't really gone. So although it had been there on the Wednesday and it hadn't gone, and some eye pain. And I was stumped. I didn't know what to do. I was with this patient for a very long time. It must have been over an hour. Sometimes you get really into things. And so I examined her, couldn't really find anything. And then I don't know where, somewhere in the back of my brain came a diagnosis. I was like, oh,
right.
Could it be this? And like you at this point, I thought, it doesn't sound really migrainous to me. It could be migrainous though, however. It didn't really sound it. Could this be cluster headaches? Doesn't sound like it. And actually what I said to the patient was, whenever I have a patient who presents with eye pain or headache or visual disturbances, the first thing I need to do is rule out the serious causes. So is this a brain bleed? Is this a tumour? So I don't think that's likely. I didn't do a CT head. Maybe I should have done. Then I think about, is this a migraine? Is it a cluster headache? Is it tension headache? That sort of thing. And it didn't really fit any of those things. So I got to the last point that you did. This is our eye. These are our eyes. What is going on in the eyes? So I thought, could this be retinal detachment?
Mm-hmm.
And I can't diagnose retinal detachment because
Me neither.
of my severe neurophobia and neuroophthalmophobia. But I can think about it. And somewhere in the depths of my brain came floaters in retinal detachment. And patients with retinal detachment can have loss of vision, but also they can have these floaters. They can have loss of the peripheral visual field, which she did have. It's more likely if you're older and you wear glasses for myopia, which she did. So I was like, okay, I really need this patient to be seen by an ophthalmologist. So she was seen by the ophthalmology team the next day, and she did indeed have retinal detachment.
What did they do for it? He asked ignorantly.
Yeah, well, exactly. So I was like, oh, I've got the diagnosis, but I haven't got a clue what to do with retinal detachment. And I am not the right person to be, telling people how to manage retinal detachment. But the first thing that you do is, when they're seen by an ophthalmologist, is to do acuity. And we know that the acuity of somebody with retinal detachment can decrease. We know that we do a slit lamp examination, and we can also do ophthalmoscopy to really have a look at the back of the eye. You may need to do a CT or an MRI, possibly. And sometimes they also do ultrasound scans as well of the affected eye. So that's also a possibility as well. Now, treatment, it depends on the type of the retinal detachment. There are lots of different types of retinal detachment. So you can have exudative retinal detachment, tractional, where it's like a pull at the back of the eye and a tear. You can have a posterior vitreous detachment without a break and a tear. So there are many, many different types, and you can have hemorrhagic as well, which tends to be due to trauma, actually. So sometimes you can get traumatic retinal detachment. So how do you treat? Again, treatment depends on the type of the retinal detachment. And I would advise people to go and have a look in detail a little bit more about how we treat retinal detachment. And there are some excellent guidelines published, mainly based in America. But the American Academy of Ophthalmology do have some very good guidelines on how to manage retinal detachment. But in short, sometimes you watch and wait. So sometimes you don't actually need to do any treatment. Sometimes you may have to do some laser surgery at the back of the eye, and it's called laser retinopexy. Now, I've been reading about this and I'm still not really sure of how effective this would be or how this would be done. But again, it does very much depend on the different types of retinal detachment. Now, I guess the key thing in this case, and I guess that I want to get across, is this patient presented with some symptom that didn't really fit any picture. And sometimes our role as clinicians in times of uncertainty, because I didn't know what was going on, is to think about the most serious cause, rule that out, and then really to think about, like you did in your 5 possible diagnoses, you had ophthalmic at the bottom. We aren't ophthalmic specialists. But what we do know is how to get help from an ophthalmologist and refer to the right people. So I think it's about an awareness of possible diagnoses and who to talk to if it's a possibility.
I think also I've always been very interested in the referral conversations that we have at the sort of where we meet two specialties, and what a good referral is. And we can maybe, say to ourselves, I wonder if that GP should have gone straight to in retrospect, could they have gone straight to ophthalmology rather than going through the acute and general medicine service there? Was there any clues at the front door which would have got the patient to the right place, right person, right time? But when you're making your referral, it's always good to say, I'm asking for your opinion about whether this could possibly be X or Y. For example, here's another, in my practice, we make a lot of referrals to intensive care when our patients get sick. And one thing that I really focus on when I'm doing my medical education roles is we don't just refer to ITU or ICU because the patient's too sick for us. We don't just say, hello, I've got a patient here, there, for example, septic, and they're now too sick for the ward. Please, can you take over? We're referring to ask them to consider treatments that they have in ITU that we don't have. For example, in the example I gave, I've got a patient who's very septic. They've now had 5 liters of fluid. Their systolic still 80. Could you review the patient with the consideration to vasopressors to support them, a bit of a central NORAD or some peripheral metaraminol to support their blood pressure whilst we're treating the sepsis? Or we've not been able to manage their oxygenation. Could you see them with a consideration to high flow nasal oxygen or NIV and ITU with a view to intubation if that didn't work? So it's always good to go to your referee with a good sort of question. So I think it's much better. And this is why it's important for us to understand these things, even though we go, well, we don't do vitreal hemorrhage or retinal detachment in general medicine. But it's good to know because sometimes we have to ring people who do.
Absolutely.
And those conversations are much better when we say, hello, I've got a patient here. I'm concerned they may have had a retinal detachment. Please, could you give a assessment and get me to know your opinion? And that's better. And it allows them to better prioritize them in their workload than saying, I've got a patient here and they've got a non-medical problem. I think it's an eye problem. So I'd like you to see and take over. How urgent is that? Emergency, same day? Are they coming from another site, from another part of the hospital? I just think in my institution, they would have to come from a different site. So they're not going to know how urgently to do that unless you give them the key details. We don't know what the key details they need to hear are unless we're a little bit informed ourselves about it. So that's why it's useful to have a little overview to things that technically sit slightly outside our remit in acute medicine, but so we can have intelligent conversations to manage safe handovers of patient care.
Yeah, absolutely, Ben. I completely agree. This case stumped me.
Done me. Done me and all.
And do you know why? Because the referral letter said, could you see this patient who's query migraine, query TIA?
Framing.
So that referral has been framed to me.
Yeah.
There is that framing bias.
Yeah.
Because the first thing I think of when she starts to tell me her history is, oh, visual loss, oh, weird things in her eye. It's got to be a migraine. I went down the migraine history.
Yeah.
TIA, it must be a TIA. Does she have weakness? Any slurred speech? And you're very much geared towards that diagnosis. That has been mentioned to you in the letter. It's in black and white. And if another clinician's thought it, then it must be correct. And that's that diagnostic momentum when a diagnosis is made and it's made again and it's made again, and we don't challenge that diagnosis. And I'm not saying that we should challenge the diagnosis every time, but what I'm saying is never underestimate the importance of that history. And when I was taking the history of this patient, I thought, this does not sound like a migraine. With the ghost was just unusual in the floaters. And I was like, this doesn't fit. And the lack of the headache as well. Yes, you can get migraines without the headache, but I don't know, for me, it just didn't quite fit. So there was some framing bias. There was some diagnostic momentum there. Certainly. And I think as clinicians, we have to be aware of that. Because I was very aware that I saw that and went, oh, it must be migraine or a TIA. Clocked myself and went, now I need to think of other things. So
This happened to me very recently, a couple of weeks ago, and I'm not going to give the details because it's a future podcast episode. But a patient was presented to me as this patient's either going to have option diagnosis A or diagnosis B, but they need this test so we work out which one it is. Turns out they're diagnosis C, and it caught me out. But when it gets parceled up and presented to you as this is one or two things, and your job is to work out which it is, you have it's difficult, as you say, the momentum not to go, hang on, let's go back to basics. What else could it be? Because A, don't have the time. B, we trust our colleagues. And if someone we respect has narrowed it down to two things, we say, brilliant, they've done a lot of the thinking for me here. I'm on the home stretch for this diagnosis. And we don't want to go back to the point where when our colleagues ask us to see patients and they say, my working diagnosis is this, we don't want to go, well, we'll soon see about that, Sunny Jim. I'm going right back to basics and challenging this, because that sounds like we're challenging them.
Exactly.
There is somewhere to sit on the spectrum of don't believe anything you're told and assume everyone else has been correct before you. But there's somewhere in the middle of those two extremes where patient safety sits, and you keep a reflexive, open mind to the case whilst keeping mindful of the work that's gone on before you, before the patient arrived in front of you.
Absolutely. And, I've been thinking about this practically. If the letter said to me, dear doctor, please see this patient, and there was nothing.
Yeah.
How would that feel? Or instead of giving a diagnosis to us, should we ask for symptoms? So please see this patient who has a ghost in a left eye, instead of please see this patient who has a migraine. How should we word our referrals?
Mm.
Any thoughts?
A very common one in SDEC for me is please can you rule out oomph, please can you rule out yes, please can you rule out PE, please can you rule out postural hypertension, and yes, I can rule out whatever you like, really, but I got to rule something in at the end of the day.
Exactly.
I don't want to send someone home and say, oh, I was asked to rule out PE and your D dimer is normal, so off you pop. Or why have I got pleuritic chest pain, breathlessness there? So yeah, there is something to be said about presenting a symptom and asking for a thought. However, the referrers, they really can't win, because when they do that, we often have a bit of a moan and say, oh, for goodness sake, it's clearly this, isn't it? Why have they asked me to work them up from scratch? So we got to be mindful of that as well. There is always this thing called second reviewer syndrome, where if you are the second person to review a patient, we always have a moan about the first reviewer who didn't do anything right. We do it to GPs probably do it to us, and whoever sees a patient further down the line says, what were these clowns doing before they got here? And that's kind of human nature, but it's a shame. And I think down that road, you can get more cynical. And at the end of the road is something called burnout, where you've only got nothing nice to say about anyone. So something I always try to keep an eye on when I hear those kinds of conversations. People are doing their best with the resources that they have.
Do you know, absolutely. And I think you're absolutely right. Having had time off with burnout, I am so much more. We're all doing our best. Sometimes people have good days and sometimes we have bad days, and we just have to support each other, look after each other, and be kind to each other.
Yeah, give people a little bit of grace.
Yeah.
It's burnt there.
Yeah. And do you know what? Last week I was at work. It was quite a busy shift, and I'd been back to work after a little time off, and it was a little bit overwhelming. And one of the healthcare assistants came up to me and he said, "You feel it too?" And I was like, "Feel what too?" And he said, "Overwhelmed." And I said, "Absolutely." And he said, "I didn't realise doctors got overwhelmed."
Yeah.
And I was like, "Yeah, I get overwhelmed most days. It's a challenging environment." And he said, "Shall I make you a cup of tea?" And I was like, "Do you know what? That would be lovely."
Hmm.
He made me a cup of tea. He sat next to me, didn't say anything.
It's not even about the tea. Maybe you don't even drink tea. Maybe you don't want a cup of tea, but the act of being given one, that's quite therapeutic. It's like someone's made time for me to do that.
Yeah, and I sat down and it was a lovely cup of tea.
Yeah.
And it gave me a bit of a, I can do this.
Yeah.
So
The
if
intention behind it is
intention,
yeah.
yeah. So if we are at work and we've seen people who are maybe not having as good a day as they would like, a cup of tea, coffee can make the world of difference.
That's a nice little note, I think, to end the episode on. I enjoyed that conversation. I mean, there's the clinical work about moving into areas that we know nothing about, but I like conversations about how we think and about how we frame diagnoses for the next person, receive those frames. And I always like that conversation about how we work on the liaison, on the boundary between two professions, two specialists within a profession, and how we make that work well for us and for the patient. So thank you for that, Amie.
Thank you very much, Ben. Thank you to everybody out there for listening. Old listeners, new listeners, please rate, review, and subscribe to the podcast. Download us wherever you get your podcasts. And a huge thank you to the Royal College of Physicians at Edinburgh. Thanks for listening. Goodbye.
See you later. Bye.